Good afternoon, everybody. Myself, Dr. Pradipta Biswal. I am Assistant Professor in the Department of Pulmonary Medicine, SCB Medical College, Cuttack. Today, I am going to speak on principle of use of steroids in COVID-19. Now, India is facing the second wave of COVID-19. As we can see in the graph, already in April and May, we have touched 4 lakh, caseload has gone up to 4 lakh. Now it is slowly declining and reached up to now it is 2 lakh per day. As on 25th May 2021, the COVID-19 cases have crossed 26.9 million with 3.07 lakh deaths. How the second wave is different from first wave? The second wave is evolving at a phenomenal speed as compared to the first wave. In India, new double mutant strain of SARS-CoV-2 virus has been discovered, and this new virus strain, which contains 2 mutations, is highly infectious. And in this second wave, the pediatric and younger individuals are getting infected in addition to older ones. And the symptom of second wave seem to be extremely variable. So this second wave is causing much more devastation in our country. Now, we have a basket of treatment in COVID-19, and from that basket, we have a set of empirical treatment which is practiced for COVID, which includes corticosteroids, antiviral, hydroxychloroquine, which can be used as a therapy as well as in prophylaxis. Then azithromycin, anticoagulant, convalescent plasma, and ventilation strategies. And in this basket of treatment of COVID-19, corticosteroid has got its place. And today I am going to discuss the role of steroid in the treatment of COVID-19. Now, when we look at the overview of the main recommendation around the world, there are 2 recommendations. One is strong recommendation and one is conditional recommendation. As we can see in this picture, the steroids and the anticoagulants, they are included in strong recommendation. So these 2 drugs, they are the backbone in the treatment of COVID-19, especially in moderate to severe cases. Now, this is a graphical presentation of pathophysiology of COVID-19 infection, which there are actually 4 phases in COVID-19 infection, which includes incubation period, symptomatic, early pulmonary phase, and late pulmonary phase. Incubation period ranges from 2 to 7 days, on average 5 days. And symptomatic, there is always overlap between symptomatic phase and early pulmonary phase, as we can see in this graph. And therefore, this phase is very critical in the treatment of COVID-19. And ground glass infiltrates usually we see minimal in symptomatic phase, but it's keep on increasing when we go from early pulmonary phase to late pulmonary phase. In late pulmonary phase, we face some lung fibrosis are also seen. And the treatment approach is based on this pathogenesis. That is, in the early phase, antiviral are the drug of choice, and the late phase, the anti-inflammatory play a role. So, 2 main processes are thought to drive the pathogenesis of COVID-19. Early phase, there is a replication of SARS-CoV-2. In later phase, there is a dysregulated immune or inflammatory response to SARS-CoV-2 that leads to tissue damage. So, the later stage is causing much more devastation as compared to early stage. If we contain the disease in early phase, then prognosis will be better. Now, what is this dysfunctional response? Dysfunctional response is unable to inhibit viral replication and elimination of the infected cell. That is exacerbated inflammatory response leading to cytokine storm, which is manifested as ARDS and DIC. Loss of immune regulation between protective and altered response due to exacerbation of the inflammatory component lead to disease progression. Now, what is the rationale behind the use of corticosteroid? As I already shown, based on this understanding, it is anticipated that antiviral therapy would have the greatest effect in the early course of disease. And immunosuppressive or anti-inflammatory therapies are likely to be more beneficial in later stages of COVID-19. So, potent anti-inflammatory effect of corticosteroids might prevent or mitigate these deleterious effects. Now, So many trials are, the recent trials are there, like adrenal trials, DEXA, ARDS trials, along with other prior data have shown the benefit of corticosteroid for sepsis and ARDS. Again, however, their use is not universal. And in COVID-19, corticosteroid use in various formulation and doses and for varying duration in patient were also studied, but in several small randomized control trial. So this pandemic has further highlighted the need of strong RCT or randomized control trial to guide the appropriate management. Now it is the landmark trial. It is a landmark trial as we consider the use of corticosteroid in moderate to severe case. This is called recovery trial. It is a first and large trial. Recovery trial, it is a randomized control trial which include 176 NHS hospital in United Kingdom to determine the effect of dexamethasone on 28 days mortality in hospital patient with COVID-19. Here the dexamethasone 6 mg daily for 10 days are given and is compared with the standard care of treatment. And in this trial, the patient who received dexamethasone group had significantly lower 28 days mortality as compared to those who received standard care of therapy like oxygen therapy or patient on NIV support and better survival. So this study was the first and largest study to identify that steroid decrease the mortality in COVID-19 patient. Now another study is Remap trial. This Remap trial, it is also a randomized control trial which aimed to determine the use of whether the effect of hydrocortisone on mortality and organ support in patients with severe COVID-19. And this demonstrated that there is a high probability of superiority of corticosteroid use as compared to no steroid use with respect to organ support. Now another trial is REACT trial. In REACT, it is a meta-analysis where the investigator aimed to determine the association between administration of systemic corticosteroid and mortality among critically ill patients with COVID-19. It was a meta-analysis. And they showed that use of corticosteroid in critically ill patients, including those with COVID-19, was shown to be associated with lower 28-day all-cause mortality. So evidences of use of corticosteroid in moderate to severe COVID-19 are meta-analysis in both all patient and critically ill patient shows reduction in mortality, high heterogeneity due to different doses and study designs, and large site, particularly recovery trial, shows convincing treatment effect. Now coming to the doses of corticosteroid in COVID-19. A dose of 6 mg of dexamethasone OD is recommended. 7 trials varied between 5 and 14 days, but currently up to 10 days given. If dexamethasone is not available, alternative glucocorticoids such as 150 mg of hydrocortisone or 40 mg of prednisone or 32 mg of methylprednisolone can be given, which is equivalent to 6 mg of dexamethasone. Now corticosteroids in pregnancy and pediatric patients. It recommends using of dexamethasone in hospitalized pregnant women with COVID-19 who are mechanically ventilated or who require supplemental oxygen. But safety and effectiveness of dexamethasone or other corticosteroid for COVID-19 treatment have not sufficiently evaluated in pediatric patients. Now coming to the guideline, what guideline says about the use of corticosteroids? NIH COVID treatment guideline says dexamethasone, a corticosteroid, has been found to improve survival in hospitalized patients who require supplemental oxygen, with the greatest benefit observed in patients who require mechanical ventilation. Therefore, the use of dexamethasone is strongly recommended. Now this is a guideline. In guideline, it's a clumsy slide, but we don't have to see everything. Only we can see that in the hospitalized patient who are requiring supplemental oxygen, there either we can give dexamethasone or we can give dexamethasone plus remdesivir if remdesivir is not available or it's contraindicated. In hospitalized patient who is requiring very high flow oxygen requirement is there, or patient on non-invasive ventilation, there also either we can give dexamethasone or dexamethasone plus remdesivir. And patient who is requiring invasive mechanical ventilation or ECMO, there we can use dexamethasone, or in ICU also we can use dexamethasone plus tocilizumab. Now what WHO says, WHO recommendation one is recommendation of systemic corticosteroid rather than non-corticosteroid for the treatment of patient with severe and critically COVID-19. It's a strong recommendation and based on moderate certainty evidence. And recommendation 2, not to use corticosteroid in the treatment of patient with non-severe COVID-19. It is a conditional recommendation based on low certainty evidence. Now it is our Ministry of Health and Family Welfare Government of India guideline. We can see in moderate disease, anti-inflammatory and immunomodulatory therapy has got a role. Here we can give injection methylprednisolone 0.5 to 1 milligram per kg per day for 5 to 7 days, but we can give up to 10 days also. And equivalent doses of dexamethasone can also be used. And in severe disease also, we can give injection methylprednisolone 1 to 2 milligram per kg per dose for 5 to 7 days, and we can extend up to 10 days. Now this all we have discussed about the use of systemic steroid in moderate, severe and critically ill patient. Now we'll talk about the use of inhaled corticosteroid in mild cases of COVID-19, which is now included in AIIMS guideline also. This is a beautiful paper by Dev Singh and group, which says that in previously healthy people and patient with chronic lung disease, if they are symptomatic with complaining of cough and fever, and if we give in this patient, if they are infected with SARS-CoV-2 and if they are complaining of cough and fever, if we give inhaled corticosteroid very early in the course of disease, that is mentioned like we can see in the picture on second day, then the development, the symptoms like cough and fever, they subsides, and also dyspnea and pulmonary infiltrate, they decrease, which later on can lead to ARDS and death. Therefore, in asymptomatic patient and in mild symptomatic patient, there is 95% of recovery with the inhaled corticosteroids. Now, another study is there for inhaled budesonide is STOIC study, the steroid in COVID-19 study, which also tell that if there is a it is done in 146 patients for more than 18 years, which concluded that if we use inhaled corticosteroid early in the treatment, it will decrease the symptom process, and also recovery is faster as compared to patient who have given the usual care like antipyretics or symptomatic treatment for cough. Maybe the proposed mechanism for the use of inhaled corticosteroid maybe is that it decreases the replication of viral application, which is in vitro data is there, or sometime, and it also decreases the downregulation of expression of AC receptor gene. Now we can see here in the AIIMS guideline, in treatment of patient with mild and asymptomatic disease who are in home isolation, there the inhalation budesonide has got a role, which is given via DPI or MDI with spacer at the dose of 800 microgram BD for 5 to 7 days. It is to be given if symptom like fever and or cough are persistent beyond 5 days of disease onset. So in summary, the pulmonary or respiratory phase, it is a time to have inflammatory response due to presence of viral debris. So, hence the role of corticosteroid is there, and steroid should be initiated early in the pulmonary phase to counter the immune dysregulation. An ideal time for steroid initiation is after 8th day of symptom, when the virus is very low replicable and inflammatory response is about to settle in. So, if steroid is started early in viral replication phase, then there is a chance that virus will replicate more. Methylprednisolone is better than dexamethasone, and dexamethasone is better than prednisolone. Now, methylprednisolone, it's penetrate much better into lungs and bind better to glucocorticoid receptor among all steroids. So, when we are when we are planned to give steroids, and it's very important that steroid should be given to right patient in right time and in right dose and for right duration. It's very important. Thank you.